Good morning. It's a pleasure to be able to address this group. I am so proud to be part of Utah because I know when I travel throughout the nation, they look at Utah as a leader in innovation. Because truly, we have some of the best, and I think I heard Annette say it, brilliant, or was it Rana? I'll give you both credit, minds here in our state. And the ability for us to move projects forward and implement those projects is what puts us on the map. So again, I'm from the Utah Health Information Network, UHIMSS, and let me tell you a little bit about UHIMSS. I think most of you know us, but John, I don't know how much you know us, so I want to tell a little bit about us. We started in 1993, and it was a community organization that said there has to be a better way and a way we can interoperate with claims data and financial data. And if we use standards, we know we can reduce the administrative burden. So out of that came a standards group and work towards creating what we call now a clearinghouse, or a way that financial data passes through our network. But in 2007, we had providers that came together and said, you know what, this works so well. The one connection to get to many payers, the one connection a payer can get to many providers. Can we do that for providers? This was before ARA. This was before meaningful use. This is how advanced our futuristic physician minds were. And they knew they needed to coordinate care. They knew patients would not stay in their clinic and only see their clinic. And they knew they needed to have that data to be able to treat that patient. And so we started planning for our clinical health information exchange. We are the state designated clinical health information exchange. We had our first data source in 2009. We have since continued to grow in depth in making sure we have more and more data that's more meaningful for our physicians, but also in breadth and ensuring that data reaches across many data sources. Are we done? No. Bob, we've got a lot of work to do. But I would say, and I would offer to you, that part of an HIE's job is to help and facilitate that harmony that you talked about. So when Pimmy said, do you have any innovations? What are you guys doing? I said, oh, wow, we're doing so much. What can I talk about? We were fortunate to receive advanced interoperability grant from the ONC. And we're doing some great things. And should I talk about the fact that we're connecting EMS, emergency medical services, so that they can get allergy information and treat that patient? Should I talk about poison control and how poison control is connecting electronically with emergency rooms and with the Department of Health, and how they can do syndromic surveillance of environmental poisonings? Or should I talk about the fact that we are connecting regionally? We are connected with Colorado and Arizona, connecting with Nevada, Nevada, Idaho, Wyoming, and I'm forgetting one, Nebraska, and trying to move that data so that it always follows the patient for treatment. And then we were talking, and I said, what are we doing all of this about, right? It's the patient. The patient has to be the center of all this work. And our hope is, with all this interoperability, with all this technology, that we really are improving the health of our community and that patient. So I'm going to focus on giving patients access to their HIE record. Okay, I'm going down. So I talked a little bit about HIE, and HIE is, as Bob suggested, is trying to bring disparate clinics, EHRs, systems together to be able to share data. And it was designed initially for providers and hospitals to be able to have that data to treat patients. But what about the patient themselves? And what about giving patients access to their own records? And so I'm going to talk a little bit about open notes and why even have open notes. And I know the UHIMSS chapter members, right? You keep track of our LinkedIn account and our newsletters, and you saw a wonderful article written by our HIE committee member, Sherry Vanderhoof, and our HIE committee. So I'm going to do a shameless pitch for our committee. So if you want to get more involved, we do have an HIE committee that is continuing to move forward and educate our community on HIE. But why? What's the value of the patient having their own notes? Patient engagement, the ability for patients to be able to see their records, the ability for patients to even correct their records. And as Sherry told me, because the university has bought onto this initiative, University of Utah Hospital, it's a little bit scary initially. What? Let patients see? I don't know if any of you saw that Seinfeld episode where Elaine saw what her doctor wrote about her, and she was so upset. Let patients see what doctors are actually saying about them and treating them. Will that get the patient more engaged? Will that get the patient involved in their health? Because as I did a UHIMSS showcase a couple of years ago, a doc came to me and he says, what power do we have? Unless the patient is willing to take their diabetes seriously, unless they're willing to control their weight, unless they're willing to stop smoking, we have a hard time trying to take care of our patient. We're just treating the symptoms and helping them get along with those bad habits. So, to ensure the patient and provider are on the same page, to have those more complete records, and certainly it is a vital tool. And what we're seeing more and more is those patients, we call them with polychronic conditions. They have more than 2 issues. And I hate to say this because I'm into this age, it happens when you start aging over 50. I won't tell you how much over 50 I am. But you start getting these chronic conditions that have to be treated and are usually treated by multiple physicians. So, the first thing you're going to say, another portal? Because that's what we hear from patients. Got a portal with my physician. I got a portal with my hospital. I got a portal with my payer. I've got a portal with my specialist. And by the way, I can look up my latest mammogram at a different portal. So now we've just added another portal. But what we hope is that this portal will pull together all that disparate information into one record. Kim, I still hear your voice several years ago at a conference when you say, I use one of the largest healthcare systems here in Utah, but I had an emergency visit outside of the healthcare system. How do I get that in my record? How do I combine it? And we do know, at minimum, in our largest healthcare systems, and we have a couple of real big ones here in the Valley, 39% of those patients seek care elsewhere. And at the highest number, we have some clinics that a great number are referred out. And I imagine, this is for the lab testing and the radiology testing, on average, 58% are seeking care elsewhere. I will tell you, I use one of the largest healthcare systems here, but my doctor's an independent physician. Her data's not in there. I may have an emergency visit as I'm traveling. That data's not in there. How does that get all in there? How does the patient get a complete record? And how do we put the patient in control of sharing? Should the patient be able to get that complete record and make a decision of where it goes so that when I'm in Dallas and I need services, I can pull this record up and I can push it via direct, secure messaging to the current emergency room? There is an opportunity for patients to really get involved in their care coordination. So, as we looked at this, because we knew we weren't going to compete with the big personal health records, we knew that are some that are so good, we're not in that competition. What we're here is to provide a combined record. But we knew, and I appreciate Crossroads talking about the security, we knew we had security we needed to deal with, and privacy. How about ease of use? Bob, you talked about it. Ease of use for the physician, but patient too. And usability, and more importantly, as my board members will remind me, sustainability, as I look at my board member over there. So, pilot model. Let's try a pilot. We need a very simple design. We need very low cost in that. Let's try it with a couple employer groups, because employer groups are a little safer than just putting it out on the internet and said, anyone come forward. And let's collect feedback for 6 months to see the value. Because again, it's about the patient, it's about the user. Is this going to work? And so we started in January and going up through July. The biggest issue, and I imagine many of you cybersecurity professionals can help us with this, is ensuring access to the right record and ensuring who's on that other end. Because we really don't know if it's you that's now Teresa Rivera or if it's me, right? And so we need to make sure that we have some authentication process in place. We need to ensure that there's individual logins, good security. Annette probably will tell me, good security. And two-factor authentication. And there was one more thing that's a little more complex with any health information exchange. It's the patient matching. And I think we heard it a little bit earlier with John. It's not easy when you have this disparate records, and I'm known as Teresa Rivera under my doctors. Under the hospital, they put me as T.L. Rivera. Under another provider, I might be Terry Rivera. They might have my old address, not my new address. And so trying to match that and ensure you have good records and that you're showing that patient their own data is so critical to any patient portal. In addition, keeping the data secure. So all the cybersecurity professionals here know, encrypt the data. At rest, in motion, anytime you can, that data is encrypted. We have to ensure the enrollment is secure because, again, as wonderful as the internet is, it does leave you open and vulnerable. And auditing must occur. And I'm looking for my Crossroads person. He probably could give me all the steps, and he's probably checking them off on his list as we go through this security piece. So what did we end up with? A very simple display. Can you imagine the patient being able to view that same patient summary, that meaningful use has required all of the providers in this room, all of the hospitals in the room, to be able to submit? And yes, we have to kind of modify it a little bit for usability because a patient needs a little more translation. But also, wouldn't it be great if there's an untranslated version that is meaningful use ready that can be submitted and accepted by any EHR? Allergies and adverse reactions. Isn't it great that I can verify my allergies and I can make sure and put on there, oh yeah, watch the shellfish for me, and share this with my provider, just as if they came to the HIE, they would also have. And my visits, my latest visits. And this is where I get excited about the Open Notes initiative. When we have a data source that is willing to share their notes, like, and I'll just call you out, University of Utah, that data is there. So I can read my notes, and I can see my actual physician's notes on what needs to be done. Medications. We heard the opioid abuse, and I think, I keep hearing us move up in the scale. That's not something we want to do in Utah, but the last I heard we were 4. I would say it's not I'm not as worried, of course I'm worried, of the drug dealer and user in Pioneer Park. I'm worried about my mother that had to have an opioid for a simple fall and making sure that she gets off that opioid and how we help her stay off of that and come back to health without that dependence on that. Medication reconciliation by the patient, being able to share it with your physician, and your physician being able to have this so they also can help the patient and bring them to good health. Problems, conditions, and diagnosis, always very important. Important for the patient to share with whoever their caregiver is, be it emergency medical staff that needs to know this patient had a severe fall and was treated in an emergency room a couple of weeks ago. And so don't go down the drug use path. Go down the fall path and set them up for an MRI right away. So current progress. So I'm excited about this because it is an implementation. We've got 105 users. Notice it's masked for me of who is the users. 179 lookups. Again, we're interested in this. We're interested in tracking this because we know then they're using it more than once. And feedback. So we were fortunate to have those two employers, and Kim was good enough to let her students in her HIT class do it. So how great is that, to have an HIT group actually look at this and give us feedback? Patient onboarding, not the easiest, because the authentication requires you to know a lot of facts about yourself. Sometimes I can't remember what my mortgage is. And yes, I had a mortgage with such and such company 10 years ago. Do I remember who they are? And what was interesting about the UVU testing is we didn't even consider the fact that we have a lot of people with no social security number. They're foreign. They're here students studying here. So another opportunity for us. Patients match more than one record. We know in our data that independent lab is probably the hardest to link. And so trying to link that data, we've default to the unlinked. And so you have Teresa Rivera and Terry Rivera. Also, sometimes, and we've gotten good feedback, patient record is missing some of the data. And that's feedback we can give our data source. If you would expand on this, and we give that from our providers, but then hearing it from the patients is so much more meaningful. Detail. We want detail. So, completing the pilot, we'll be conducting a patient survey, and I'm excited that we have a graduate PhD candidate that's going to help us with some of that surveying, and then finalize the business model for our board. And then I will leave it for our next discussion. Thank you.